Assalamualaikum everyone, welcome back to my YouTube channel. Today the topic of discussion is pruritus ani. Pruritus ani is a common symptom and is characterized by a sensation of perianal itching, scratching can damage the perianal skin and further exaggerate the problem. What are the causes? Causes will be lack of cleanliness, anal or perianal discharge, as well as fungal infections, Candida albicans, transmitted diseases, parasites, enterobois vermicularis, dermatological disease, psoriasis, drug tetracycline, and metronidazole. Management treat the cause: intravenous vermicularis, albendazole, candidiasis, antifungal. Improve the perineal hygiene. Wash the perineum with the water at least twice daily in the bath or shower after expiring the bowel. Use dry towel and hair dryer. Hydrocortisone ointment is also recommended. Then here is the topic of anal fissures. Anal fissures is a longitudinal split in the lining of the distal and anal canal extending from the anal verge to the dentate line. More than 90% of the fissures are acute and resolve spontaneously. Chronic fissures that have failed to heal after 6 weeks of conservative measures usually require pharmacological as well as surgical interventions. They appear as shallow fibrotic ulcer and indurated edges. More than 90% of the fissures are located in the midline posteriorly. Anal fissure is less than 10%, is much more common in women and may arise following etiology can be constipation, diarrhea, reduced blood supply, as well as bowel disease. Pathophysiology is related to trauma from either the passage of hard stool or prolonged diarrhea. Artery in the anordum cause spasm of internal anal sphincter. This spasm of sphincter causes vasoconstriction of anal canal and thus reducing the blood flow and thus ischemic pain. This cycle of the pain, spasm or ischemia contribute to development of poorly healing of wound. Clinical features: sharp pain in anus and worsening during defecation that lasts for several hours. This may be associated with the passage of small amount of the fresh blood. Other symptoms include anal discharge and pruritus, anal pain leading to the fear of the defecation. So hard stool is formed and the passage of this hard stool aggravates the spasm of the sphincter. Examination: fissure can be seen as a tear in the anal margin or the apparating and buttocks, and prerectal examination is usually not possible due to pain and should be avoided. The objective of treatment is to relax the sphincter which eliminate the pain and restore the blood supply of anordum and thus promoting the healing. Here is the management of the anal fissures. First of all, high fiber diet, sheets, bath, stool, softener, more than 90% healed. If not healed, then chronic anal fissure more than 6 weeks duration. Then next step is GTN 0.2% ointment, BD for 8 weeks, not 50 to 70% healed. Then diazepam 2% ointment, BD for 8 weeks, 70 to 80. Then botulinum toxin 20 IU injected into AIS, more than 80% healed. And if not healed, then next one is surgery, LIS advanced flaps, and GTN is full form of the GTN is glass-light titrate, IAS is internal anal sphincter, and LIS is lateral internal टमी। तो यहाँ तक हमारे पास जो है मैनेजमेंट हो गई एनल स्फिंक्टर की, और इसके अलावा हमारा प्रूराइटिस एनआई भी हो गया। तो कोई क्वेश्चन हो तो पूछ लें। अल्लाह हाफिज़।